Hello guys, today I am going to take you through an operation which a lot of you have been requesting for a long time. So today we are going to do arthroscopic PCL reconstruction using a hamstring graft. So I have already uploaded a video on ACL reconstruction and various procedures such as graft harvesting and graft preparation that is involved in that. So I am not going to cover that. If you need to watch that video, how to harvest the graft, you will have to visit my previous videos. So today my goal is to take you in a step-by-step fashion as how to do a successful arthroscopic PCL reconstruction using hamstring autograft. So this is our theater position. We are all set up. So patient is supine. We do use the tourniquet. We are going to use the hamstring graft. I always keep this area free just in case the graft is thin and we need to harvest the peroneal, then we can harvest it. My screen is right there. This is one operation where I use CM because I don't do as many PCLs, so I do use CM for my tibial tunnel just to ensure that I am in the right place. So CM is going to come from this side. My trolley will be on this side. So next I will show you the sag this patient has and the instability that he has. So if you see this patient definitely has got a sag. You can see this. Now this is the normal position. So if you drop PCL, can you see this? This is the posterior draw is positive. So this is the normal position of the knee. This is a positive posterior draw, and this is a typical sag that you see in the PCL. So next thing I will show you the portals that I will be using for this particular operation. So there will be various portals that we will be using. The first portal that we will be making will be this high anterolateral portal. So this will be our entry. Now then we will be making an anteromedial portal. Then under vision, when my scope is in, we will be making a posterior medial, and then the last portal that we will need is this low anterolateral portal. So the high anterolateral portal, low anterolateral portal, anteromedial portal and posterior medial portal. Now this is my joint line. This is the tibial tuberosity. This is the patella. 2-3 finger breadths. This is the main here. So this is where I am going to harvest my graft. So I am not going to show you how to harvest the graft. If you are visiting my channel for the first time, search ACL graft and you will find 2 or 3 operations that will explain everything. So I will join you once I have harvested my graft. So normally my portal will be somewhere here. I am just going to be high anterolaterally. So this is my anterolateral portal. So I am just going at an angle of 45 degree, and I would recommend you to watch my basic arthroscopy video. Let me go inside the joint and then I will join you. So now I am into the joint. My second portal is this high anteromedial portal. So I am just gone inside, and then I will shove my shaver inside and I will join you. So once you are inside the knee, you will do a general inspection. So I am just clearing the ligamentum mucosum, and once I have cleared it, I will just do a general examination of menisci, both medial and lateral, and if there is an issue I will address it, and once I have dealt with that, I will join you back and I will show you what to do next. So I have done the general examination and the knee itself looks pretty good. There is no degenerative changes. This is a young guy. The ACL seems to be pretty good, and clinically it was also good, and so was radiologically. So whenever you are dealing with a PCL injury, always examine ACL. Don't believe reports. Do a clinical examination and do an arthroscopic examination. So now once you have done, now I am going to talk about the bundles of the PCL and how to identify them and where do we aim to put our portal. Just to orient you, this is the articular surface of the medial femoral condyle. So this is lateral aspect of medial femoral condyle. This is the attachment of the PCL. So this is coming in the way. So let me just shave this so that it doesn't bother me when I am explaining you. So I am in my high and tight anterolateral portal. This is the scope that it's showing. Now unfortunately our main scope has malfunctioned. I am trying to get another one so that we can show you better. So this is the lateral aspect of the medial femoral condyle. So this is the whole attachment of the PCL. Now the PCL has got 2 bundles. Anterolateral bundle is somewhere there. So it's right up the notch, very close to the articular surface. So the anterolateral bundle is the main bundle, and this is very close to the articular surface. Can you see the articular surface? The articular surface is just there, and this is your anterior limit of the anterolateral bundle. So this is all anterolateral bundle. Posterior medial bundle is somewhere down there. So up is anterolateral, down is posterior medial. So the next step will be just to debride it. I'm just going to debride this area now. There are two philosophies. Some people believe in trying to save whatever fibers of anteromedial bundle remaining, just try to save that. Let me see if I can save some fibers. My next step for me now is to put my shaver in my anteromedial bundle, anteromedial portal, and start debridement. So I'm just going to come in from the anteromedial portal, and then I'm just going to use a shaver just to debride it. And this, once I have done just gentle debridement, then I know that my area where I'm going to put my anterolateral bundle, because when you're doing a single bundle, you are reconstructing the anterolateral bundle. So we will reconstruct the anterolateral bundle. So let me just do some debridement, and once I have debrided that, I don't think that video will add anything if I just show you how I debride it. It's just a simple thing. Once I have debrided that, I will come back and I will join you. So I've just used the shaver, I have debrided. This is where my anterolateral bundle will be. So it will be high up. I am just going to point it to you. Once you have debrided that, then we need to go into the posterior aspect of the knee, and that maneuver is called Gilchrist maneuver. So you just go next to the ACL, you keep going in, and then you reach to the back. I think there is still some soft tissue which I need to take off, and let me just take it off, and then I will show you how to go in the back of the knee. So I'm still in the anterolateral portal. So I'm just going, this is the stump that I have debrided. I'm just going into the back of the knee. So just going there, and once you fall back, now this maneuver is called Gilchrist maneuver. And once you have gone in the back, then you are ready to make your posterior medial portal. So what I wanted to show you is that my scope is still in the anterolateral portal. Now if you see this transillumination, this will give you some idea about where your anteromedial portal will be. Now the key of anteromedial portal is don't be too close to the femoral condyle, because you need working access, and also you don't need to be too low, because then you need to work on behind the back. So it needs to be high. So I'm just going to poke it here, and I'm going to show you how it looks on the screen. So I have, if you see my transillumination point, I have gone even 1 or 2 centimeter proximal to it, and I'll show you. And then I have come back. Now this is the back of the tibia. This is the back of the tibia. And now I will be able to, I want to have an access. Can you see this? This is the posterior condyle. So I am far away from posterior condyle of the femur, because if I'm too anterior, then there is no way I will be, because my work, I need to work behind the tibia at the origin of the PCL, which is here. So you need to have an access. So use a needle to make sure that you have got good access in the back when you want to debride it. So this is how you make your anterior medial, posterior medial portal. So stay away from femur, and then stay away from the back of the, this is the back of the tibia, this is the back of the femur, so that I have good access. So now you can see I've got good access. So I'm just going to use a needle, knife over it, and then we will shuttle something like a messenger rod, and then we'll put something like floppy sheath to keep so that we have this access all the time, and we are not struggling when you're getting an instrument in and out. So transillumination is here. I am proximal to it, because if you're transilluminating, it is within the joint, so you'll be too close to the condyle. So you need to be up and behind. So this is where it will be. Now I'll take a knife, and then I will, in the same line, I'm just going to come inside into the posterior aspect of the knee. So my camera is still in the anterolateral portal. I'm just using a knife just to create a place, and then we will pass a sheet. So this is just to give you an idea. Once I have made my hole, and then I will pass a sheet, and I will show you how it looks. So once I have put my knife, and once I have put my needle, I use a shaver just to create a space, because then you don't want to be struggling when you are coming in and out. So shaver is a good safe tool. So I'm just going to widen my posterior medial portal, and then we'll pass something like a messenger rod, and I'll show you, and then we'll pass a cannula on top so that we can start working on our back. So I think that's done. So this is our messenger rod gone. We are just going to pass a sheath on top. So our messenger rod, we will take it out since our cannula is in. So we are just going to pass a little bit more, and then we'll start working on our back. So now I have my shaver is in the posterior medial portal, and I am keeping the shaver towards the tibia, and then I am just going to start debriding the stump, the PCL stump on the back of the knee. And this is the tedious process, because it can take a lot of time. So just key is that keep the shaver blade either down or up, but never on the back, because the vessels are on the back and you don't want to be going anywhere close to that. So let me just work a little bit and then I will join you back. So once, if you are doing combined ACL PCL, actually your life is much easier because ACL is also out of the way. Now because our ACL is intact, it just makes our life slightly more difficult. But you can see that I am staying close to the bone, and also the other difficulty that I have is that I have only 30-degree scope. This is one stage. If you have got 70-degree scope, that will be very, very useful, because then you can look down. But anyways, let me keep working on the back, and once I am debrided it, then I will join you. But key is, can you stop the shaver please? Never ever shave it in this direction, because this is dangerous. Either in this direction, you can be like this, but never like this, because then you don't know what you are shaving. So can we start again please? Now when we do PCL, it's all about the killer turn. Then we talk about killer turn, killer turn, killer turn. So our entry, if you are using transtibial technique, should be slightly lateral to the midline, because then the killer turn will not be that acute, and also it should be low down. So to avoid the killer turn of the graft, two things. One, the graft entry should be low, and hopefully I will show you on the C-arm, and also it should be slightly lateral to the midline. Now some surgeons will make a safety incision on the posterior medial border, and they can feel both the medial and lateral colliculi, and then they can actually, and they don't really use the C-arm, because then you can actually virtually feel it where it is coming. But now you can see that I am slowly working my way down, and if I can stop shaving, can I just have my probe please? So if you can see here, I am starting to look down. So this is the end of the tibia, and this I am trying to go look down. So just I am trying to clear this is all down. So I think I need to go a little bit more down. So let me continue my hard work, and once I have done it, but I think you guys have got an idea. The idea is, this is 30-degree scope. If I had shown the same thing from 70-degree scope, you would have seen much better. But anyways, I just want to have an idea, so I think you have got this idea. So I'll continue to work, and then I will join you back. So now normally I work from anterolateral portal. Now I am in the anteromedial portal. My scope is anteromedial portal. That gave me some more access towards the lateral aspect, and I have shaved that. Just a second. So this is the posterior medial portal. This is the back of the tibia. Just let me withdraw it. This is the edge of the tibia. So we are falling back off the tibia. So now I think I have done enough. So now next step will be to pass our tibial jig and try to make our tibial drill hole. So now this is the Arthrex jig that we are going to use today. Now one good thing about any jig, if you are using any jig, is that it should be closed, so that there is no option of this going out on the back and trying to damage anything. And also if you see here, they have, this is, I think this is not straight, this is curved, and this is deliberately curved in order to avoid the ACL, so that you have got good access. So now next step will be to pass this jig from the medial portal and drill our medial transtibial tunnel, so that graft can pass through the tibia. So far we have used two portals, mostly anterolateral portal, anteromedial portal. These are high portals and posterior medial portal. So this is going to go inside, so it goes upside down, and then you rotate it, and this is gone at an angle of, this is set at an angle of 65 degree. So I'm just going to pass it inside the knee and then I'm going to show you how it looks. So this is the tibial jig gone. So if you can see, if you make it horizontal, it is right in the back. Now it's very hard to show it from here. Let me try to put my camera in the posterior medial portal and see if I can show you from the back. So now you can see that we are quite down. I have cleared it quite low down. So this is confirmation because my camera is now in the posterior medial portal. And now since it is down, the next step will only be to pass our drill bit. So we are just going to drill it, and while drilling, this is a closed system, but still I am going to ensure that I am keeping something like a curette in the back so that there is no chance of the drill going in the back and doing any harm. So now we are drilling under direct vision, so just continue to drill please and just go slow. That's it. So now we can see that this has come out and it is under direct vision. But if you want, you can keep something like a curette in the back just to prevent it going any further. Once we have drilled it, then I'm just going to take some CM images to see if it is in the right place, and once it is in the right place, then we will do our tibial tunnel. Look at the AP. These are our two views. So this is AP, this is the center, this is slightly lateral, that is what we want. This is the fibula. If you look at this is the slope, this is the bony avulsion, you can see. So our drill is just there. So this is an 8 mm graft. So once we drill it, it's going to be there. What you don't want is to be high. You have to be as low as possible at the level of insertion of your origin of the PCL, because then you avoid the killer turn. So to avoid the killer turn, lateral and as low as possible. If you don't know about the killer turn, just read about it. This is the biggest problem while doing the PCL. So now I've just got this curette. I was struggling to put a curette through the anterior medial portal. So I've got this straight curette. You have both options. You can go through the anterior medial portal, then you have this curved curette which you put. I have got a straight curette and I'm just going through the posterior medial portal. My camera is also there, but I've taken my cannula out. So we'll drill it. You just have to make sure that you are in the direct vision, and in no way this guide wire or this drill bit should go in the back. So once you are drilling it, you can drill it all the way across, but when you feel you are about to reach end, you can ream it with your hand, but I usually do it with the drill. So we are almost there. So you can see that we are out. So now once we have drilled that, I am going to pass my shaver, and then I am going to clear this hole so that when we pass the graft, the soft tissue doesn't catch. So it's hard to show because now once you make this hole, you lose the pressure of the water. So I'm just trying to use the shaver to just eat the soft tissue. Unfortunately, I don't have access to the cool vapor, which is also good equipment and which does the job very fast. So this is the idea. I'm just going to take this off. Now because we are losing the pressure of the water, I'm just putting my finger here. Now we have taken a suture pasa, so we are going to take the suture and we are going to take it out in the back of the knee. So this is our suture out from back of the knee. So now my suture retriever has gone from the anterior medial portal, and then I have caught this, and then I am trying to bring it out from the anterior medial portal, if Prashant can show here. So we have gone from here, gone on the back, from here I have retrieved it out. Now this can be quite tricky job, but on this occasion we were lucky. We're running out of luck because a lot of equipment issues today, but on this occasion, for this, it was very smooth. Now if you must be wondering what time are we going to make the lowest anterolateral portal. So this is the point. So I'm just using a needle, and under direct vision I need to have an access. So I'm just going to pass this needle and then I'm going to show you on the camera. So we talked plenty about anterolateral portal. So this is our articular surface. This is high. This is right up to the notch. So our anterolateral portal will be somewhere there. So I have got this access. Now I have ensured that through this portal I will have access to the anterolateral portal. So I'm just going to make a stab hole with a knife, and then we are going to make our femoral tunnel for our PCL. So this is our beef pin, this is the articular surface, this is the trochlear notch. So I want to be high, this is the halfway, this is anterior medial bundle. So this is the anterolateral bundle, this is the posterior medial bundle. So I want to recreate my anterolateral bundle. So I'm just going to go, because our graft is around 8 mm. So I just want to be at least 4 mm from the articular surface. So let's that be, okay, can we just go in please? So if you see here, we are right up and then we are very close to the articular surface. So this is the area where the anterolateral bundle is. So we are just going to make a drill hole, and so first we are going to go through and through with beef pin, and then we will use an 8 mm drill bit or drill, because our graft is 8 mm. Chalo. So once you drill, the knee should be in around 90-95 degree of flexion. You don't want your knee to be extended. So this is our beef pin gone. So we are going to measure our tunnel length, and then depending upon what size, depending on the tunnel length, we will use loop endo button, and then we will show you the next step. So if you are in the right space, if Prashant can show from here, this is where your beef pin will come out when you are drilling or you are making your femoral tunnel. So if you see that our drill is very close to the articular surface and very high, so this is where anterolateral bundle is. So we are going to drill with our 8 mm drill. Come on Manish, go. So if you're using an Arthrex system, then it's absolutely beautiful. You decide how much you're going to bury, and then it's fine. For us, we have got this fixed end loop button, which is a problem because flipping, if you go a little bit deep, you blow out, and if you go a little bit less, then it's hard to flip. But that is how things work out. But that's fine. We deal with poor patients and we have to make them better, and this challenge is nothing when you get the reward when they do very well after the surgery. So it's okay. So this is our tunnel done. So I can show you right within the tunnel. So once its tunnel is done, then we need to pass another suture, and I will show you how. Now suture shuttling can be a problem, and you will see a lot of videos, but suture shuttling has not been shown properly. So now this is our first suture shuttling which I have shown. Now this will go from our low and tight anterolateral portal and will come out on the top. So this is one done, but you keep the loop here. Now these are two sutures. The black and white suture is the suture that went through our tibial tunnel, and this white suture is gone through the femoral tunnel. So I am now, my suture retriever has gone from anterior medial portal, and I am trying to bring this out into this anterior medial portal. So Prashant, if you can show it here. So now both the sutures are into the anteromedial portal. This is the tibial one, this is the femoral one. Now we need to pass one of them, and so that both the sutures, now this is a separate tunnel, this is a separate tunnel. Now we need to pass one suture so that at least one of them becomes redundant and the other becomes the suture through which we are going to pass our graft. So we are just going to put a small knot and tie them together. And once it is tied, just make few tie knots. So Manish is ensuring that this is not. Now we hold one end, and with other hand we are going to pull it out. Let's hope it's all fine. So beautiful on this occasion. God has been kind, no troubles at all. So we're just going to open this up, and the next step will be passage of the graft. So last time we have got loop here. This was an open end. We have made few knots, and this has also become a loop. This is our graft. Now Manish is our main person. He prepares the graft. Look at how beautifully he has prepared the graft. So in India you have this luxury that you have got this really talented assistant who will do graft preparation for you. In England you have to do it yourself. So beautiful graft ready to go in. Abhishek, can you pull it up? Yeah, just be very kind. Aram. Abhishek can be very, very aggressive. So just keep pulling. Come on Abhishek, well done, well done. So all these sutures have come back on the top. That's it. So we are pulling the graft slowly first into the tibial side. That's it. Now this is where you need a lot of patience. So keep going, keep going, keep going. So there was a slight struggle in going the graft. So if you have that, then just keep the tension on this side and cycle a few times and the graft will sink in automatically. So this is the trick. So just keep cycling and then the graft will continue to sink in. Can you see it? It's just going in slowly. So can you see this? This has beautifully gone into the femoral tunnel. Just let me make it slightly, give it a wash and I will show you better. So can you see this? This anterolateral bundle is beautifully recreated. So we just now need to flip on the outer side and then we need to fix the tibial side. Now if you're using a sliding loop, then it's not a problem. For fixed loop, this is a problem because your tunnel has to be perfect. So once you think that you have flipped this, both sutures will become free. So this is free, and now this will give you a rocking movement. So this is flipped. So it's all done. On this occasion, we were very lucky that we didn't have any struggle, but this can be a point of great struggle, especially if you're using fixed endo button. So now we are giving it a cycling. We'll do it at least 15-20 times. So you know creep is permanent deformation under constant load, so you need to learn a bit of biomechanics. So this is, you don't want your graft to become too loose. So we'll continue like that and then I will join you in a second. We are using a peak screw, and then when we are doing it, you need to give an anterior drawer. So one person is giving anterior drawer and I am going to pass this screw. So we are giving posterior drawer and then we are putting the screw inside very deep till you get a good purchase. That's it. That's good. That's brilliant. That's like it. That's really good. So that's all done. So now we have tightened it. You can see the sag is completely gone and there is the draw test, posterior draw test is completely gone. So this is an excellent result. Now I'm just going to put my scope inside, just giving a good wash, and then it's just a matter of closing the portals and starting the rehab from tomorrow. Now this is also an important part of the operation, to clear the debris, because there are a lot of bone debris that is generated. So you just want to clear it till you see properly. And also while tightening the screw, I think when I was so involved, I was saying to do a posterior draw. No, you do an anterior draw because you want to bring the tibia in the front, and then you want to tighten the screws in a position where the graft is at optimal length. So it's anterior drawer, not the posterior drawer. Now look at this beautiful creation of us. So this is a nicely created posterior cruciate ligament. I'm just going to give it a good wash. I think I've already shown you, but do spend some time clearing it, clearing the debris. And usually at the end I put my scope in the suprapatellar pouch, and this was the trick that I learned from Mr. Ajay Adhikari, who was in Epsom, to give it a good wash in the end before you close the knee. Any procedure, even if you do meniscectomy, take it in the suprapatellar pouch, give it a squeeze in the popliteal fossa, and then come out. So this is our graft, nicely recreated. I think it looks a bit red, but I can tell you this, that the graft size is beautiful, the sag is gone, and the knee is going to be extremely stable. So this is how you do a PCL. It has got a lot of critical steps which I think I have talked, but hopefully this video will give you confidence in doing the procedure. So this is the end. So this, we are going to take this off, and you should not be using it, but this fiber wire can be quite handy to create a loop endo button if you're fixing coracoclavicular ACJ dislocation. So I'm just going to cut this, then routine closure, and that's the end of the operation. So this is all skin closed. So this is our site where we harvested the graft. This is our anteromedial portal. These goes for our anterolateral high and low anterolateral portal. And last but not the least, don't forget the posterior medial portal. Sometimes you're struggling, and when closing up you can forget that you have made a portal here as well. So this is all done. We are just going to use some crepe bandage and some well band, and then we'll put him in a ROM brace and we'll start rehab from tomorrow. So viewers, this was a demonstration of how to do an arthroscopic reconstruction using a hamstring graft. I think I have tried to make this video elaborate, taking in a step-by-step fashion that what are the critical steps and what do you need to do in order to avoid any possible difficulties or complications. So hopefully this video will give you a lot of confidence in doing this procedure. I was thinking of making this video for a long time, but because of lack of time I was not able to make it, because recording takes a lot of time and effort. And thanks to Manish, he is always helping me in my all arthroscopic cases. He is a very good assistant. I am very lucky to have him, and he prepares the graft very well, and he takes half of my hassles away. So thank you to him, and I appreciate his hard work. And I hope you guys find this video useful in your clinical practice. And I have enumerated all steps, especially suture shuttling, because that can be a problem to get your head around it. And if you like this video, please give us a thumbs up. If you're visiting my channel for the first time, please subscribe to the channel, as you will find many other useful videos, and also share and like the channel. Thank you.